Okay, okay, sudah. Thank you, thank you. Okay, Yasin, we start. Okay, your tier 3, history taking, very important to. We're going to the physical examination dah like we lecture dah.
Belum.
Belum. Okay, belum. Okay, this is what we call clinical skill. Clinical skill consists history taking, physical examination, diagnosis, investigation, and management. This is what we call a clinical skill. History, physical examination, diagnosis, investigation, and management. We are talking about clinical skill. So your year 1, year 2, you learn the basic of knowledge. This is year 1 and year 2. You learn the basic of knowledge. So in year 3, you start to learn clinical, which include ability to take history and present history, doing the physical examination, making a diagnosis and differential diagnosis, and planning for investigation. That is you punya ni. Management is plus and minus point. It's good to learn something about the management, but you focus more during your final year. So you have gone through your preclinical, which is the basis of knowledge. The clinical consists anatomy, physiology, biochemistry, pathology, microbiology, and pharmacy. You all know all this, and you already passed. If you already passed your preclinical, it means that you already have the basic knowledge which is adequate to bring you further to go in clinical year. That's the reason, because the reason they learn your preclinical is that to have to make sure that you all have some sort of knowledge, standard knowledge, which is we consider adequate to build on that. Without the preclinical knowledge, we cannot build on that. No way you're going to build the clinical knowledge without preclinical knowledge. So you don't think that preclinical is only to pass exam. It doesn't work like that. Preclinical is the basic knowledge for your clinical to build it on it. Remember that. So if you think that finish the exam, the preclinical, thus I can forget about the preclinical knowledge, you're going to waste your learning process. The thing you have learned and the thing you have accumulated, you wasted it. By right, you are supposed to build on it. So clinical is more of application, and then because your bread and butter is patients. That is what you are being trained how to treat patient in their medical problems and medical condition. So this is application time. So it's different set of thinking process, and totally different set of thinking process. It's no more theory. It's about the practical to use whatever you have learned and to accumulate the new practical knowledge. So what is history? Okay, basic thing is that what is the thing that you have to have? You're able to, what is your learning point when you learn about the history, talking about history? First, the ability to extract the history, very important. You must able to extract the history from the patient or from the caregiver or the parents. That is the skill. Second, ability to critically evaluate the history, very important. Knowing history is not enough. You must able to critically evaluate the history. Don't become a narrate only. Kalau narrate tak payah ambil belajar you all. Narrate ni dia bagi staff nurse siapa ke, dia ambil history, dia cerita balik ke kita orang. That is narrate. But your job is not to narrate. Your job is to evaluate the history that you have taken. And then the other thing you have to have is that the ability to present and communicate. if no point you can extract but you're unable to communicate, either in writing or in the presentation. This is both skill you have to have. You have to have it. Because we don't know what do you know. We only know what you know, whatever you tell us. Things that come out to you may know one whole book, but if the thing come out to your mouth is only one piece of paper, so we think that you only know one. That is the only thing you know, though you may know more than that. But that's too bad. I mean, because you don't have the clinical skill of to present, to communicate. So history, yeah? Whom do you get the history from? From the patients, if it's big enough adult. But in children, you know that communication skill is not that fully established, fully developed. They don't have enough vocabulary, enough ability to express what they feel and what they think. So you depend history on mothers, caregiver, patients, father, and siblings. So the most important with mothers, caregivers, patient if they are big enough. Sometimes you need both history from patients and mother in order to make a conclusion. Some fathers are quite observant. Some fathers are useless. It depends how lucky you are. And siblings depend the age. The older the sibling, the more they can help you in to give you the history. But the principal thought process is that in your brain, you have to have this investigative thinking process, such as asking when, why, where, what, who, which, and how. And then you have to have your brain must think in chronological order. You don't think 2 days ago, after that 4 days ago, or 1 week ago. You try to think in terms of what 1 week ago, 4 days later, 2 days later, and or 4 years old, 6 years old. If the present child is 8 years old, then 8 years old, what happened? That's how you think. Yeah, you think. Though that sometimes the event occur in 1 day, the cost of admission, but the total the duration of things that occurs can be in in chronological order, temporal, and then it have to be clear and logical. When you clerk your case, you're clear about the patient problem in logical order. If you're not clear, clerk again, clerk again until you clear what's happening. Okay, history, the first thing you see is chief complaint or chief complaints. So what is a chief complaint? Chief complaint is why the patient come to see you. Where doesn't matter where you are. Is it you in a primary in the GP clinics, you in the KK, you in your clinics, you in tertiary hospital? There are reasons why the patients see you or brought the children see you. That is the chief complaints. You have to identify chief complaint. Sometimes the patient got fever for 5 days, then suddenly they develop shortness of breath. Then they bring the child to see you. So you know the chief complaint is shortness of breath, because that's the main reason why the child was brought to see you, shortness of breath. So the chief complaint is shortness of breath for how many 2 days. Yeah. So if let's say fever for 5 days, nothing else, fever, because the fever is intermittent, so bad, and brought the child, the patient, the parent brought the child to see you. So the chief complaint will be fever for 5 days. So you have to identify the chief complaint or chief complaints. Very important. If you cannot go at this first stage, I'm able to identify the chief complaint, something is not right. You come to see doctors suka-suka. They don't waste your time to see doctor suka-suka. They went to come to see you because there is reason why they come to see you. And your job is to identify why the patient come to see you. So most of the time it consists of symptoms. Fever, shortness of breath, jaundice, cyanosis, semua all symptoms. Abdominal pain, wheezing, stridor, all the symptoms. They come to see you with symptoms. What we call symptom. So then after that, you go to history of presenting illness. History of presenting illness is of present illness. It depends how you look at it. History of presenting illness is that patient is having probably is the illness probably is bronchopneumonia. What is the presenting of the bronchopneumonia? Patient maybe have present illness is asthma. So patient can be shortness of breath because of asthma. So the present illness is asthma. So what is history of presenting illness? Presenting illness. I mean that, and the thinking is that when it happened, where is it? Let's say presenting illness, patient coming with jaundice. When the jaundice start? Why is it? How bad the jaundice is? What is the complication? Or talking about patient coming with shortness of breath. When it started? Where is it? Why is it? Because it's choking or not? What the cause of it? All the things come to your brain. And then it has to be in chronological order. You don't think yes, it's okay. You can decide. Oh, 2 days coming 2 days ago. What happened in the first 2 days? What happened on the day of admission? So you go by that in chronological order, and you have to decide the illness is acute or chronic. Let's say the child coming because of fitting seizures, 2 episodes of seizures for past 2 days. So you know it's a acute case. Let's say coming with fever for 3 weeks, fever for 1 month. You know there is a chronic problems. Or patient got acute exacerbation of asthma for 2 days, but he's been asthmatic for 5 years. So you know it's acute based with the chronicity of the disease. Though it's acute presentation, but the disease is chronic. So you have to decide on that. What is it? When you listen, when you clark the history, and you have to go on the severity. You must have understanding of severity of any chief complaint that come to see you. If patient coming with shortness of breath, right? So what is it? How severe the shortness of breath is that? If the child able to drink, not able to drink, the child with shortness of breath with cyanosis, you know it's severe. Child shortness of breath with intercostal recession, you know it is severe. The child with tachypnics only, without the subcostal intercostal still able to drink normally, so you know it's not very severe. So in any chief complaints, there must be a severity. Even fever also, you have to decide how severe the fever is, and then the complication also tell you the severity, if there's a complication or not, because that tell you the severity. And then look into the positive history and negative history. Let's shortness of breath with tachypnea without cyanosis. So the cyanosis will be negative history. The tachypnea will be the positive history. But that tell you something. That tell you that the child is not that severe. Let's say the child got tachypnea with cyanosis. So both are positive. It means that it's severe. So negative history, the positive history are equal in importance. Don't if you don't ask properly about negative history, because negative history help you to determine what to do next. How severe is it? Because severity tell you the level of management that needed, to this patient. If the patient got cyanosis, you know that the first thing come to your mind, patient needs some oxygenation, or patient need more serious interaction like intubation. But if the fever is just tachypnea, perhaps you look, patient doesn't need oxygen yet because just tachypnea only, but without cyanosis. The child got fever with tachypnea without cyanosis. So you know perhaps person doesn't need oxygen. So the severity tell you the level of management. That's why you need to know the severity and positive history and negative history. You must be clear about positive history and negative history. Many of you present only positive history, but did not present the negative history. So what after that, when you have cleared all those things, then you go to the systemic review, system by system. Go to systemic review, system by system. Go by systemic review, system by system. So the systemic review consists of one, ask the sometimes the first systemic review is that you ask related to the chief complaint, because you want to know things related to the chief complaint. You go through things that child is there, is not there. Let's say the child is having shortness of breath. You want to know about in terms of let's say you want to know about the cardiovascular cardiovascular systemic review, autopnia and autopnia and PND. PND, autopnia and PND. You want to know about that. So you want to know about that, the autopnia and PND. So what you do is that you ask about that, though sometimes you not sure what relevant is that, but you know shortness of breath, one of the cause is heart failure, and they come with autopnia and PND, proximal nostril dyspnea, dia susah nafas waktu malam. So it still be a history of present illness, though it is a systemic review but related to the chief complaint. So it's still an HOPI. But let's say you go about shortness of breath but ear discharge. Then it is not related with HOPI. It is related with shortness ear pain. So it's still a systemic review, but we're not related with HOPI. So you have to decide when you do the systemic review. Systemic review, though you go system by system, you have to decide some systemic review related to HOPI, some systemic review not related with HOPI. You have to decide on that. Then after you complete this, then you go to the other history, to complete your history taking. You have to do all this. Taking what the other history, past medical history. Past medical history, you have to understand is the past medical history. Okay, if the patient got acute exacerbation of asthma, and then the asthma is not a past medical history, it is the present illness. That is asthma. The present illness is not a past medical history. If the patient got asthma, but he have got appendicitis which operate 3 years ago, then the appendix will be past medical history because it's not related to asthma or not related to the chief complaint. So anything related to chief complaint is not a past medical history. I said you kalau patient kami shortness of breath, the chief complaint, and then the diagnosis acute exacerbation of bronchial asthma, the underline is asthma. So bronchial asthma is not it is part of our HOPI. But if you got appendicitis, faham ke? Faham tak?
Doctor, I think we lost you a bit on the last part. Your voice was a bit stuck.
Macam mana?
Appendicitis?
Appendicitis.
Before the appendicitis, what happened?
So appendicitis tu, let's say coming with shortness of breath. You know, patient chief complaint shortness of breath, which is due to respiratory cause. So appendicitis tu become what?
Past medical history.
Past. Okay, kalau patient coming shortness of breath due to asthmatic attack. Shortness of breath ni 3 hari saja. Tapi patient is known to be asthmatic for the past 4 years. So asthmatic is past medical history.
No, because it's related to the HOPI.
Yes, it become still HOPI. Because this HOPI is history of present illness. Definition HOPI is history of present illness. So the illness, asthma is the illness that caused the acute exacerbation of bronchial asthma, result in shortness of breath. You understand that?
Yes, doctor. Understood. Understood.
Okay.
Yes.
Okay, the other history important is birth history, antenatal history, feeding history, dietary history, immunization history. Okay, little bit about birth history. You have to know the antenatal, the natal part, and postnatal part. But sometimes if the patient feed at the age of 2 months, and then you found out that the patient birth history, patient got birth asphyxia. So the cause of the seizure is due to birth asphyxia. So birth history will become what? Anybody?
Both.
Birth history can be part of HOPI still, because it related to the chief complaint seizures for the age of 2 years. Still, we would like you to present it in the HOPI because it relevant to the chief complaint. Unless the patient got fever seizure at the age of 8 years, developing well at the age of 8 years, then only develop seizure. And then you know that birth history not related at all with the chief complaint. And then the birth history will stand on its own. Understand that?
Yes, doctor.
Yeah. So about feeding history, you have to know the feeding history, dietary history. The feeding history is since birth, what milk they use, and then when the weaning, and then when they start adult diet, what is the current diet. Immunization history is what things that they've been immunized with, what things is not been immunized with. You have to realize that sometimes we do want to test you. We ask you what is the immunization schedule of the patient. If the patient have a immunization schedule, follow the national guideline. Sometimes we just want to tease you on that. Remember that. So we have the right to ask you. But you have to realize that you need to know this because it helps you to give a whole view, holistic view of your patient. Developmental history. But in order to take developmental history, you must know the developmental parameter, especially the milestone. You're clear on that? You must know the milestone, the progress of the milestone. When you talking about developmental, we're talking about four main things: gross motor, fine motor and vision, language and speech, and social. So the gross motor is usually, we ask you, the milestone is usually is when the patient can turn full, when the patient can sit with support, when the patient can sit without support, when the patient can stand, when the patient can take a few steps, when the patient can run. That is the milestone. Fine motor is that when the patient can reach transfer object between two hands, when the patient can reach both hands, when the patient can reach in one hand, when the patient can has the coarse palmar grasp, and the patient got a fine palmar grasp, and when the patient can have start to have cube, 2 or 3 level cube. Vision is when the patient can look um, as 90 degrees, other 80 degrees, and how the patient can differentiate colors and those things lah. Vision is a bit difficult to test in baby, but by the testing, patient can see. Usually parent you can follow when the patient can follow light, when the patient can uh, uh, follow object. That's vision. So that is, we call it milestone. Language, when the patient can speech and hearing sekali, language, speech and hearing. When the patient can say cooing, babbles, first single words, and then after that sentence. And then usually if patient can have good language, they can hear. If not, you have to check for the hearing test. And social, when the patient recognize the parent, stranger anxiety, and then start to play around. Cognitive is relative. Sometimes I put it different because it intellectual, which is a bit more detailed. We're talking about how do we assess patient intellectually. But this is optional. But the 4 things you have to know. That is the progress. And then the next question is what the patient can do now. Okay, for cases that not related with CNS, sometimes we just want a rough like guideline about the developmental. But if patient is related to CNS, let's say patient develop fitting at age of 6 months, patient develop delay developmental. This is the kind of case the developmental history need to be comprehensive. Okay, any question? Aktif this level, kau ada question tak?
I think so far so good, doctor.
Yeah, sure. So the next one, family history. You must be able to construct the family tree, at least 1 layer, 2 layers. If there's not a genetic disease involvement, at least you for the parents and the siblings. But if it's a genetic disease, you have to do at least at least 1 to 3 layers. The patients, the sibling, the parents, and then the above the parents. Depends. Sometimes you 5 level, because it tell you the consanguineous and then the genetic. The consanguineous is the close marriage. I think I'm not mistaken, second cousin or third cousin considered consanguineous. And then genetic, because certain genetic disease, when you do a family tree, then you can see the pattern of inherited. Is it X-linked? Is it autosomal dominant, autosomal dominance, or recessive? Autosomal dominant, autosomal recessive. It tell you those things when you do the family patterns. And the other history, drug history, medication history, social economic history, daily activity in school, a certain condition, a chronic disease. Let's say chronic nephrotic, chronic asthma, chronic pain disease, connective tissue disease. Important to know the school history and daily activity history. And then certain condition like environmental history also important, because certain disease related to environment like asthma, where the house is near to the factory, to the fat or palm oil factory, near to the main road, right, where a lot of lorry. And then what the facility in the house, especially the cases infective, especially the gastroenteritis, it help you to tell you the facility, how it contribute to the disease. So we need to know all those things. Okay, after you have clock, then what? Then there is come the critical thinkings. Actually, critical thinking should come at the same time, with the history taking. That if you have, or if you mastered the history taking already, then but slowly you have to practice to learn critical thinking. And the critical thinking is based on your knowledge of the anatomy, pathology, physiology, biochemistry, biomicrobiology. This is the basic of your knowledge that help you in the critical thinking. So that's why whatever you learn in preclinical are very important to develop your critical thinking. So what is the essence of critical thinking? It is the question you ask yourself: what's the problem? Where the problem is? When the problem started? Which process? Is it infection, inflammatory, tumor, endocrine? Which system involved? Which the main system involved, and any other system that get along with it? Very important. You have to decide when patient, when you clerk the case, when you sit down, you can decide which system mainly involved. Especially, is it respiratory? Is it cardiovascular? Is it CNS? You have to have clear picture in that. And is any other system affected? Is it a chronic disease or acute disease? What about the severity? Is mild, moderate, severe? You have to have this. Important, very important. And the complications. What complication due to the disease that they present the child having? Let's say patient got nephrotic syndrome. What is the complication of medication they use? That steroid. Is there any evidence of the child having steroid toxicity? So that is the part of the complication. It's part of the puzzle of history. Then after that, you round out, then you start to present your history. As usual, introduce your patients properly. They are not a chair, they are not a table. Everybody got names, age, and sex. Very important. Introduce your patient properly. Tell us the source of the history. Is it from the parent, mothers alone, both parents, father and mother, or is it from the child, whoever are giving you the source of history, or is it sometimes from the book that at the side of the patient, bring along with the patient? So you tell us the source of history, and tell us the chief complaints. Chief complaint, you don't need to characterize the symptom. Just give the chief complaint only. Fever for 5 days, rash for 5 days, and then shortness of breath for 1 day, cyanosis for 1 day. You don't need to characterize the symptoms. Don't need to characterize, because you're going to characterize it in the HOPI. You tell us the complaint also. Even the parent, when they come to see you, most of the time they tell you, oh, anak saya sawan 1 hari. Mak anak saya sawan, awak saya ada susah nafas, anak saya ada demam. That's what they only tell you. And HOPI, anything related to chief complaint. Remember that anything related to chief complaint is in HOPI. Anything related to chief complaint. Even when you do systemic review, you found that the symptom that the patient mentioned to you related to the chief complaint, it will be in HOPI. Remember, so don't mix up HOPI and systemic review. So always when you ask when, why, what, and where, the chronological order, severity of the illness, the complication, and remember the positive history and negative history are same importance. Don't focus only positive history. Remember, negative history also is the same importance to the negative history. And then you can present your systemic review that not related to HOPI, other medical history, other history that we discussed earlier, and later on what happened in the ward if you are being asked. And if you clerk this patient, it's good to know what happened in the ward. Remember that. Chief complaint is until the patient admitted to the ward. After that, it is a progress in the ward because you already interfere with the management of the case. So, but the progress of the ward, that doesn't mean not important. It can still be important about the cases. And then remember, no magic bullet. You don't expect to hear this lecture, they're definitely pandai to take history, no such thing. The only way you can get it internalized inside you is by make a lot of practice. The more practice you do, the better you are. Itu saja. And when more patient you clerk, more patient you present, more patient you think about it, and the better you are. That's what is it. No magic bullet. Okay, any questions? Ada apa questions? You ada question tak? Dengar tak? Macam tak dengar ya?
Setakat ni tak ada, Doktor.
Yeah, clear.
Yes. Kalau
So
tak
I
clear,
expected you no question. I expected you know everything now lah about taking history.
Tak juga, Doktor. No. I think we have to
Maybe-
learn by doing.
yes, maybe during the clinical, in the clinical setting.
Yalah, tapi apa ni you nak belajar, you tak boleh clerk patient pun. There is sad thing about you all. Nasib you tak baik lah, tak boleh clerk patient. Boleh clerk patient ke? Dah boleh masuk dah?
Belum lagi.
Itulah. Tak tahu setakat mana you all boleh belajar. Tak apalah. We do our best. Any question? Tak ada? Tak sama you present other people's history then you clerk your own history. Believe me. Tapi nak belajar ni sagut kena marah lah. Pasal you all ni kena marah sikit mengajuk. Kan? Ya, betul ke?
Rasanya tak kot.
Budak-budak zaman sekarang ni mengajuk cepat mengajuk. Kan kena tegur-tegur. Ya ke?
Tak ada, Doktor.
Ya, betul lah. Tak tahu lah.
Tak.
Kata sensitif budak sekarang ni. This Z generation. Dia beritahu kita, you don't understand Z generation. Dia tak beritahu kita orang tau. They tell us, you don't understand, we are X generation. So we are very sensitive. Betul lah. You X ke Y ke Z generation, I can't remember lah.
Kita orang pun tak tahu sebenarnya.
Kita orang Y, Doktor.
Y generation, belum Z lagi lah.
Kita orang belum sensitif lah.
Okey. Dia problem Z generation ni. Dia membesar dengan betul, dengan all the screen. Okay, ada apa lagi? Tak ada question Okay, we stop here. Okay.
Thank you, Doctor.
Okay.
Boleh, Doktor. Thank you.